Hi everyone, I'm Dr. Mark Trolice. I'm a reproductive endocrinology and infertility specialist in Orlando, Florida, and I am delighted to be with you all today at this fantastic event sponsored by PCOS Challenge. I'm on the board of that wonderful organization, and it is a true privilege to be part of with you again, like I was last year. And I've been asked to speak about infertility treatment options for women who are struggling with polycystic ovary syndrome. So let's get right into it. What we're going to accomplish with this talk is to review the diagnostic criteria for PCOS. It's primarily a clinical diagnosis and should be based on the accepted criteria. Women with PCOS are absolutely at increased risk for reproductive as well as medical complications, and we'll review that as well. The management of PCOS really needs to be evidence-based and proactively offered as indicated. So why are you all here today? Well, the real sad picture is that 1/3 or more of women reported that they needed more than 2 years before they were diagnosed, and nearly half required 3 or more professionals before they were diagnosed. And that's really such a disappointing statistic, but one that just speaks to the frustration that you all have over not being either taken seriously or not getting answers to your questions. So in that same study, few were satisfied with their diagnostic experience, about 1/3, or even less with the information they received, as you can see, about 16%. So the most common concerns that they had in that study was mostly difficulty losing weight. About half of them had that, and about half of women actually with PCOS have elevated body mass index. They also complained about irregular menstrual cycles, and of course, we're talking about ovulation dysfunction. Well over 70% of patients with PCOS. Interestingly, there are about 20% of patients with PCOS can have regular monthly cycles, even if they're not ovulating. And clearly, infertility is a major complaint of patients with PCOS. So, this is a pictorial about what a normal menstrual cycle is. So, if you look at the beginning stages, day one of full flow of your period is sort of like midnight in a clock, okay? At midnight, it's the end of the day, but beginning of the next day, okay? So day one of your cycle is actually the end of the prior cycle. And that's where FSH levels from the pituitary gland start increasing to select that dominant follicle in the ovary, the follicular cyst that's going to make the dominant egg, okay? And you can see in this pictorial that this is a cyst on the ovary. Hundreds are getting ready to ovulate. Only one makes it. The rest die off. So that cyst eventually will release the egg. This is the LH surge right there, okay? That induces ovulation, and that's what's detected in the urine. When you see these people talk about using an over-the-counter ovulation predictor kit, that's what they're detecting, that urine surge of LH. And then within 24 to 36 hours, you'll be ovulating. The second half of the cycle, that cyst left behind, is making progesterone to support the lining of the uterus. Now, if we don't see a pregnancy hormone called HCG within about 8 to 10 days after ovulation, those hormones go down. So we look at this bottom picture. Estrogen is the dominant hormone. Progesterone starts going up after ovulation to support the lining, and estradiol and progesterone go down if they're not pregnant. And this is the lining of the uterus. The lining builds up, stabilizes for optimal implantation, and then sheds if there's no pregnancy. I want to speak a little bit more about this lining because that's very important and risky for PCOS patients who are not ovulating. Is what happens is that they're not making progesterone, okay? So the lining keeps building up, and there's no progesterone to stabilize it, and this continued estrogen production from the ovaries, as well as the body's adipose tissue, which are fat cells, that causes too much buildup, and it's a precancerous change that can even lead to cancer. So what happens in PCOS patients? None of this, okay? There's no regulation. There's no synchrony of the brain signals to the ovary, and it's really chaotic. That's why abnormal uterine bleeding, because the lining overflows. Think about having a hose in the pool and forgetting to turn the hose off. The pool overflows, so there's no good rhythm for menstrual cycle ovulation. Even if your cycles are monthly, you may not be ovulating. So what is PCOS? Well, depending upon the study that you read, you'll see statistics of 6 to as much as 20% of women with PCOS. So you'll see 1 in 10, but sometimes 1 in 5, okay? So 50% of these women can go on to get, are having trouble getting diagnosed. And as you saw the statistic earlier, taking 3 or more health professionals to be able to make that diagnosis. 50% develop diabetes before age 40 or pre-diabetes. A lot of cost in the healthcare system because of PCOS and significant risk of endometrial cancer, like we talked about, 3 times the usual risk. And that can lead to, obviously, endometrial cancer, which is life-threatening. So this is what patients present with. They have irregular cycles, they have acne. Hirsutism is dark terminal hair that is turned on from the elevations in male hormones, particularly testosterone. So it's not new hairs that are forming, but light gets turned to dark hair. Okay, the soft vellus hair gets turned to dark hair. And where does that happen? In the male pattern area. Upper lip, chin, sideburns, neck, chest, lower belly, lower back, upper inner thigh. And so hirsutism treatment is with anti-male hormone, but for patients who are trying to conceive, we obviously can't do that. Now, hirsutism could be a sign of a male-producing hormone abnormality, even tumor. So it's important that your doctor excludes the diagnosis for any more serious conditions, and we'll talk about that a little later. Obviously, obesity, big problem in PCOS. 50% are experiencing that, but 50% are not. And interestingly, the latest statistics is that patients with PCOS, their distribution of body mass index in terms of the percentages that are overweight is not much different from the general population. So that's changed a lot, okay? But let's look at this woman over here with PCOS. And PCOS has the central adiposity, which is mostly the fat around the waist, okay? So increasing waist circumference is one of the signs of the metabolic syndrome. And non-PCOS patients, when they gain weight, it's usually around the hips, okay? So think about the apple, which is PCOS, and a pear-shaped is more for the patients without PCOS. This is a sign of insulin resistance when you see dark, velvety discolorations in the skin folds, like the neck, the back of the neck, under the axilla, under the armpit, in between the fingers, and also even under the breast, folds of the breast, or the upper inner thigh. And that's a sign of prediabetes, unfortunately. Insulin resistance, big problem with PCOS. Hair loss by excessive male hormone that can lead to male pattern hair loss, okay? And of course, infertility as well as miscarriage, unfortunately. So how do we make the diagnosis of PCOS? Well, there's been lots of controversy. It started in 1990 where we got a consensus conference, and then in 2003 we changed the criteria, and then the Androgen Excess Society changed the requirements to have at least some elevation of male hormone, as well as ovulation dysfunction and ultrasound appearance of the ovaries, and we'll talk about that. So we mostly will use, though, the 2003 Rotterdam criteria, where you need 2 out of 3 of these criteria. So some measure of elevated male hormone, which is either elevations in testosterone or the issues of the hair growth. Okay, so issue there, as well as ovulation dysfunction. Okay, you're going to have another concern about whether you're having regular cycles or not, or lack of ovulation, even with regular cycles. And then polycystic appearing ovaries, which we'll outline. So 2 out of those 3 criteria. Okay, so what's abnormal ovulation? Well, let's talk about the teenage years, okay? Menarche is the first period that a woman experiences, okay? So in the year within menarche, okay, less than 1 year after that, so that first year, irregularity is normal. What's not normal is more than 90 days. We're considering that ovulation dysfunction or abnormal cycles, okay? That's with more than 90 days. Now, 1 to 3 years after menarche, we consider still normal anywhere from 21 to 45 days. And outside that is abnormal, okay? Anytime after age 15 or 3 years after breast development called teloche is a diagnosis of primary amenorrhea, which means that you've never had a period. And there are patients who've never had a period and then all of a sudden actually because of sexual activity will get pregnant and they never had their first period because they had an ovulation that led to conception. Okay, but not having your periods after age 15 or 3 years after breast development is also abnormal. So this is what I was telling you about the ultrasound, okay? Oh, by the way, the last part, for adults, we typically would say less than 21 days and more than 35 days are abnormal. In reality, probably 24 to 34 days or so. But even if you're within that range, you also want to not be too irregular, okay? In other words, you don't want to be 24 1 month and then 32 the next month, okay? That kind of irregularity is also abnormal. Day 1 to day 1 of full flow. What about the ovary? When you look at the ovary in ultrasound, lots of small little baby cysts all around the capsule, subcapsule of the ovary. It's like a pearl necklace, we call that on ultrasound. More than 20 of those little baby cysts. Now, all women in the reproductive years have that, but PCOS patients have a lot more of those. And what's considered abnormal? 20 or more in one ovary, okay? In these less than 10 millimeter little cysts, okay? Or the volume of the ovary more than 10 centimeter cubed, okay? You just need one ovary to have that, all right? Best time is during your period, but if a woman doesn't have a period, then she can have it at any time in her cycle. What kind of hormone test do we want to do for PCOS? Well, you want to, it's really a clinical diagnosis, as I said, so irregular cycles, and if you have unwanted hair growth that we score, and if it's more than an 8 on this Ferriman-Gallwey score, we consider that clinically significant hirsutism. So you really don't need a laboratory diagnosis and ultrasound as well, okay? So you don't need a laboratory diagnosis, but you do hormonal testing to make sure it's nothing more serious, okay? And so you're looking at testosterone levels. Sometimes we get those if a patient is very thin, doesn't have much hirsutism, but you're really not sure about whether they have that or they could have issues of eating disorders or excessive exercise that could look like PCOS. So that can help us by getting testosterone or DHEAS or androstenedione, okay? Those are other male hormones that can help with the diagnosis. And of course, the progesterone level to determine if someone's ovulating if they are monthly, okay? And if they're monthly cycles and still not ovulating, that of course would be consistent if they have the other criteria for PCOS. And then the ultrasound for the small little antral follicles, okay? Other testing, and this is what I was telling you, is you want to make sure that nothing else is going on to cause this ovulation dysfunction, like thyroid abnormality, TCOS, serum prolactin, which is the pituitary hormone, 17-hydroxyprogesterone is also a hormone that is an enzyme deficiency, could act like PCOS. It's an adrenal hormone that the adrenal gland starts producing too much male hormone because of this deficiency. Always check for glucose tolerance in patients with PCOS because up to 40% can have prediabetes, up to 5 to 10% diabetes. In patients who you're concerned about, Cushing syndrome is a very serious adrenal gland problem that can also cause increase in male hormone. But this is a very, very serious problem. We can often diagnose it easily by just taking a medication called dexamethasone and then checking cortisol level the next morning or checking the urine. I put down endometrial biopsy to make sure about the precancerous change. And if a patient has irregular cycles, typically more than 3 months, or if their lining is more than 7 millimeters, that is a concern, and we recommend endometrial biopsy. So this is what I was just saying a little earlier. 17-hydroxylase deficiency is the adrenal enzyme deficiency. That's checking for also adrenal tumors. If the testosterone is too high, we checked about Cushing's, prolactin, thyroid. And these are other issues that can cause ovulation dysfunction that need to be evaluated, but beyond the scope of this talk, okay? So what do we do to optimize fertility is that we want to make sure that your health is optimal before pregnancy. A healthier you before pregnancy is what is going to reduce the risk of pregnancy complications. So we check blood sugars, and also for diabetes, as I mentioned earlier. Blood pressure for patients who are overweight have higher risks in something called the metabolic syndrome. Metabolic syndrome are issues of pre-diabetes, elevated blood pressure, waist circumference increase, abnormal cholesterol, and triglycerides. And we also recommend a sperm analysis because 5 to 10% of men can have abnormalities even in the PCOS couple. And then also we offer them the option of checking their fallopian tubes with a hysterosalpingogram. So what are ways that patients with PCOS can actually get pregnant? Okay, so very important, and we're going to talk about briefly, is lifestyle modification. I'll mention that in a little while. For patients who have an elevated body mass index, very, very, very successful with weight loss to improve ovulation function. And I'll show you that shortly. Clomiphene citrate has often, for many, many years rather, been used to induce ovulation, but it's really been replaced now by letrozole, which is an aromatase inhibitor that has been much more successful. I'll show you a slide on that as well. Metformin we used to give out like candy, but it really is not the drug of choice any longer unless you have prediabetes or if your body mass index is above 30, there seems to be a value. I'll mention some success about laparoscopic ovarian drilling, which we'll talk about. And we're not going to talk too much about injectable medications, which are gonadotropins. These are pituitary hormones that stimulate the ovary directly to produce ovulation. Now, the medications here, clomiphene citrate and letrozole, are oral medications working indirectly through the brain. Gonadotropins are injectable medications that really mimic what the brain signals, really are what the brain signals are, that go straight to the ovary. But there are concerns with gonadotropins, of course, because they are expensive, they need monitoring, and they can also lead to over-response, resulting in a serious concern of hyperstimulation syndrome as well as multiple pregnancy. So this is a study from several years ago in the New England Journal of Medicine that looked at the success rate over 5 months of treatment with clomiphene citrate or letrozole. And for all women enrolled in the study, you could see over 5 months letrozole, almost 30% of the women had a live birth, clomiphene, about 20%. There really was not much different in the women who had a body mass index less than 30. You can see they were very, very similar. But when patients were obese, body mass index above 30, you could see letrozole much higher than clomiphene citrate, 25 to 30%. Clomiphene was around 15%. Body mass index above 39, you could see also letrozole higher than clomiphene. But what you see also is that when the body mass index is elevated, lower success rates. You see less than 30, letrozole about 35 to 40%. Here, 25%, and here about 20%. So another reason for weight loss. So if letrozole is not working, okay, an option would be to add metformin. We don't have a lot of information about letrozole and metformin. Clomiphene has been used with metformin to some success, okay, but we typically would do 5 cycles of letrozole as a means of ovulation induction. If that's not successful, then we talk about ovarian drilling. Ovarian drilling is a laparoscopy. It's a 1-day surgery, telescope through the belly button to go into the ovary with electrocautery. And this is the ovary over here. Okay, this white glistening, it's an enlarged ovary because it's polycystic. Here's the uterus. Here's the other ovary partially seen on the right. And here's the tube near the left ovary. And you just use a simple needle tip cautery. And we do puncture holes in the ovary. We don't understand completely why that works, but it drains the cysts, helps restore hormonal balance, reducing male hormone as well. So success rates, you're probably seeing, we saw about 2/3 in our study of patients ovulating after that. Some studies are having wide ranges. You see some as high as up to 80%. We saw in our study about 50% of patients would conceive if they did ovulate after ovarian drilling. But there's pros and cons of this, okay? You have to make sure that your insurance covers, because it is surgery. Okay. Yes, expertise is required for ovulation induction if you're going to use gonadotropin therapy with intraoperative and postoperative risks, particularly the more elevations in body mass index. Okay, so we in our program do not offer this in women above 39 body mass index. Okay, there may be some issues of reducing the numbers of eggs that could increase the risk of decreasing ovarian reserve, but that's typically with excessive cauterization of the ovary. Okay, so the typical numbers of punctures we do is around 10. There was a study to show even 5 in one ovary could help ovulation. We base it on the size of the ovary. Now, there has been some scar formation. See these periadnexal adhesions, some scarring around the ovary after the drilling, but fortunately, in the studies that I've reviewed, did not seem to reduce the pregnancy rate. In vitro fertilization, yes, an option for PCOS patients who did not succeed on letrozole and/or injectable medications and/or ovarian drilling. So in vitro fertilization is where we stimulate the ovaries with gonadotropins, now the injectable medications, to produce. Here we want multiple eggs. Okay, so multiple cysts are being formed, and under sedation now, after about 10 days of stimulation, using ultrasound probe, the woman is under sedation in our surgery center, and we put a needle through the back of the vagina, vacuum out the fluid in each ovarian follicle cyst, and in that fluid is a microscopic egg, and it gets drawn back into the test tube, and then the embryologist will look at that test tube to confirm that we have an egg. Okay, the procedure takes about 15 to 20 minutes. So with in vitro fertilization, there is the risk with PCOS patients of that syndrome I mentioned earlier about ovarian hyperstimulation, which could be potentially life-threatening. But what we have found is freezing all the embryos has a much higher success rate. Here, fresh embryo transfer in PCOS patients in this study that showed much higher success in frozen embryo replacement. So freezing all the embryos lowered the risk of hyperstimulation. It also had a lower risk of miscarriage if you did a frozen embryo replacement, but it did increase the risk in this study of preeclampsia, which is a blood pressure problem during the pregnancy, which could be serious. So here's what I wanted to talk to you about earlier about lifestyle modification. Now, let me outline this. This was 4 months of patients randomized to either diet, exercise for weight loss. Okay, this was 4 months of the combined birth control pill with diet, exercise, and weight loss. And this is just the birth control pill over 4 months. And as you can see, the live birth rate significantly higher with lifestyle modification. Okay, similar to birth control pill with lifestyle modification, obviously because of the lifestyle modification. So exercise, the Mediterranean diet is a great diet for health, and then daily exercise, 5 days a week cardio for at least 30 minutes, and 2 days cross-training, because muscle training reduces insulin resistance. If you look at the birth control pill only, because there is some evidence that birth control pill can help ovulation induction after being on it for a few months, but you can see it's much less successful than lifestyle modification. So what if all of those things are not an option for you? Is bariatric surgery an option? You know, the lap band and the procedures to reduce the volume of the stomach. Okay, it doesn't seem like there's evidence that it really improves fertility. Obese women who undergo bariatric surgery have the same conception rate compared to obese women who did not. Okay, but babies seem to have a smaller weight. The gestation, the pregnancy duration is less. Okay, and there seems to be a trend that there might be a slightly increased risk of neonatal deaths. This is a trend, so it has to be obviously watched and followed up in other studies. The benefits have included that there's less diabetes in pregnancy. Diabetes in pregnancy, high blood pressure in pregnancy, cesarean section, all higher risk for babies, for pregnancies where patients are overweight with PCOS. Benefits also had babies that included with bariatric surgery, they had larger babies, gestational age. So benefit there, okay? So this is just a study that look at the patients with bariatric surgery, okay? So for all patients who had bariatric surgery, PCOS patients had higher live birth rates, okay? But if you look at the patients who were seeking fertility, there really was no difference in the pregnancy rate and the live birth rate statistically. So that's interesting, is that overall, all patients had a higher pregnancy rate with PCOS if they had the surgery, but with infertile patients, those wanting to get pregnant, there really was no difference after the bariatric surgery. So this is what I was talking to you about just briefly. Gestational diabetes, preeclampsia, cesarean section, early delivery, those are complications with PCOS, unfortunately. So your health, well, with weight loss, if that is the issue, will help with the diabetes and high blood pressure, okay? So, lots of information. I know PCOS is obviously a very, very challenging problem that one is very, very frustrating. I completely empathize with what you guys are going through, and I hope this was helpful in you getting understanding about the criteria for PCOS. It is not getting lots and lots of labs, okay? It's really just, are your periods irregular? Do you have unwanted hair growth in sex-dependent male pattern regions? And or do you have the ultrasound criteria that we talked about, lots of those little baby cysts, okay? Complications with PCOS reproductive, we talked about diabetes, high blood pressure, miscarriage, infertility, abnormal uterine bleeding, all of those things. Medical complications, the metabolic syndrome, elevated blood pressure, cholesterol, triglycerides, prediabetes, weight. But patients also have issues of anxiety, depression, and we saw the hair growth, and don't forget about uterine cancer. That's why we do that biopsy. The management of PCOS, evidence-based, and be proactive, working with your patient. So you all have to be your own advocate and get a doctor who understands PCOS so that you don't have to go through 3 healthcare professionals and more than 2 to 3 years to get a diagnosis, okay? So I want to thank you for your time. This was a wonderful opportunity for me to share my understanding of PCOS with you. I completely understand the frustration. I thank Sasha Ote and William Peterson for their dedication to this cause, and I'm honored to be a part of it. And I just want to thank you for your time, and please let us know if you have any questions. Take care.